the way you keep an acute coronary syndrome patient from flipping over to an MI is you keep their hemoglobin high. And what we're learning is it's just the opposite. It's 180 degrees out from what you think. So even in the cardiovascular patients who were in intensive care because of heart failure, there was no benefit to keeping them higher, and in fact, their multi-organ dysfunction score after transfusion was improved with a restrictive approach. Very interesting. So now we've got transfusion causing immune suppression, but also associated with infections, short-term mortality in surgical and medical patients. And we're going to look at some thrombotic and we looked at thrombotic and vascular complications with the previous study. So when we go back to our list of transfusion complications, it's just not immune suppression. We've got immune suppression with a high frequency associated with increased postoperative infections. And then we have this other phenomenon of transfusion associated with increased acute heart, lung, and renal complications that are reflected in 30-day mortality. Okay? That's what's in the high category. That's what we need to keep paying attention to as we develop a transfusion guideline and start to think about, the proper role of red cell transfusion in the ICU patient, for example, or in the perioperative period. It's been at least 10 years since this information has hit our press. In Canada, they've pretty well changed their practice in ICU. Somebody did the analysis of how many more patients would be alive if they all practice a restrictive instead of a liberal transfusion practice. And it was a large number of patients. They sort of took it to heart. There's actually publications of watching them change their practice over the few years after the ABRA study was published. That was 1999. We're not there. We're way behind in the United States. We still haven't assimilated most of this information. But my feeling is this. Since it's kind of an unfolding story, and it's possible that this is all going to be affirmed, it's going to absolutely be demonstrated to be cause and effect, so that it will be clear that as of 1999 we should have known not to transfuse patients higher than a hemoglobin of 9, and that a restrictive approach where you let them get below 7 before they're transfused is safe. So a nice way to implement, if it's going to be cause and effect, a way to kind of get everybody on the same page is to have current guidelines. But here's the problem. Who can keep up, right? There's an awful lot of stuff to look at. I told you there's more than 100 articles talking about this association of transfusion with unintended negative consequences in a whole variety of patient care settings. But if you don't have guidelines, if you can't have somebody that keeps up anyway and develops guidelines, physicians will transfuse the way their peers do. We're a very it's a herd phenomenon, basically. We do what the guy standing next to us does. And the guy in the next hospital down the road is not standing next to you. So there's two things that happen. You see that docs synchronize their practice within a hospital, and that between hospitals it's wildly different practice. And of course they always say the patients are sicker, right? And then you spend the time to prove that no, they're exactly the same. What's different is the transfusion practice, and that's completely under the control of the practitioner. And also remember that Joint Commission requires that you have a good peer review system for your transfusion decisions. Can't really do that unless you kind of have some guidelines about what is and isn't an indicated transfusion. So how do you get guidelines if you've never had them before? Well, first thing you want to do is you want to really talk turkey about whether you're going to practice the herd phenomenon or whether you're going to start to move to evidence-based decision making for transfusion. When I started in blood banking, there was no evidence. There were no studies. There weren't even careful observational trials. Things just weren't challenged, and it was all about opinion. And so it was all, our transfusion guidelines were just basically a roll-up of how everybody gave blood in the institution. There was nothing more critical to it than that. But not anymore. Now there's an awful lot to inform those decisions about when to give blood. So what can you do? Well, you can pick a set from the recent literature. There's at least 15 published peer-reviewed transfusion guidelines in the last 10 years, at least. They're not generally in all patients. They're generally in a focus group. So there's one about oncology patients and platelets, and there's one about red cells in cardiothoracic surgery, for example. There's one about plasma use in patients on Coumadin. So that'd be one way to do it. You can just do it the way another hospital's doing it. Especially if that hospital's done the research and linked their guidelines to it, then it can be pretty easy. You can find somebody in your own ranks and just say, you know this best of all, tell us what it should be. Or you can actually develop multidisciplinary in-house experts by doing like an immersion orientation to the literature, and get clinicians now that understand as much as there is to understand about the appropriate use of transfusion in their discipline, and then use those people as thought leaders to move ahead a set of guidelines. Whatever you do, whichever approach you take, you have to own the guidelines in the end. You have to follow them. What you can't do is take it from the literature in another hospital, and as soon as you have someone transfusing differently, just say, well, that's not really ours anyway. So, if that's what you want, if that's what you do, then you have to stand behind it. What we did at Riverside and Grant was sort of a variation on those last two. We did put together multidisciplinary groups. We did look at the literature, but we didn't have everybody read everything. What we looked at was a boil down of what was in the published peer-reviewed guidelines and expert opinions from the last decade. And you could find themes. And I'll show you a couple of the sort of theme boil downs that were the kinds of things that the committee looked at. So here we have 2, 4, 6 professional groups with recommendations about transfusing red cells for a very low hemoglobin. What was that hemoglobin? In most cases, it was less than 6. Most of them talked about patients that had risk factors, some kind of risk factor. And you can just scan what these 4 said. You can see some of them had fairly complicated algorithms with all kinds of clinical information, demographic information about the patients. Others, like the Society of Thoracic Surgeons and Cardiovascular Anesthesiologists, were only concerned about the cardiovascular patient. They did make a recommendation, less than 7, which aligns very nicely with the studies that we looked at today as being really where you should be. They all talked about anemia with an oxygen deficit. A word about this. There's always a gray zone for patients where they don't really have critical anemia, but they have some degree of anemia, and you're concerned that they look like they're having a consequence of that degree of anemia. What the experts are starting to do, I think very nicely, is they're starting to say, it can't be that, she's got a hemoglobin of 8.3 and she's dizzy when she stands up. I understand that, but that's not life-threatening. The MI you're going to give her with the transfusion might be. So maybe we need to move the marker a little bit. And when we're talking about symptoms, we're not talking about being winded when you go up a flight of stairs. We're talking about things like unstable blood pressure, tachycardia not responsive to fluids. Show me ischemic changes on the EKG. Show me things, low urine output going into renal failure. Show me physiologic evidence that this degree of anemia is intolerable for that patient. I call it the prove it zone. And then the other thing you want to do is not only have a fairly substantial indication that you've got a problem with tissue oxygenation in the patient, but you then want to transfuse and document whether it fixed it or not. Because if the patient's got ischemic changes on their EKG and you use that as a justification for giving 2 units of red cells, and they still have the same ischemic changes, it wasn't the anemia. Don't keep giving them red cells. You've already done the experiment and shown that that was not the problem. Some of them get pretty sophisticated too, all of these, SVO2s less than 50. And what they're all speaking to, though, is do you have something close to a scientific, a measurable symptom or finding in the patient that tells you that you have insufficient tissue oxygenation. Platelets. Put them all on the table. Pretty much everybody talks about when to give platelets preoperatively or pre-procedure. Again, you can scan 2, 4, 6 expert guidelines worth. They're all saying about the same thing, about less than 50,000, less than 100,000. We don't really know why, but we're more concerned about the neurosurgical patient. Patient who's stable, not bleeding, just has a low count. What do they say? You might be interested to know the American Society of Clinical Oncology says don't transfuse those patients. Doesn't matter that their count's 3,000. They actually don't bleed enough to justify the risk that you take with a blood transfusion. Pretty much, even the British Committee for Standards in Hematology says, handle it case by case. There's not an obvious indication here, even if that platelet count is in the single digits. Just a word about plasma transfusion. The American College of Chest Surgeons has put out guidelines for managing the coumadinized patient in the perioperative period. And they're on their 2nd or 3rd version of that. They're very well researched. They're very easy to understand. They've been pretty consistent with those recommendations, and at least at the hospitals where I hang out now, our use of plasma is nowhere near in line with what the recommended usage is. For example, in the non-bleeding patient, they say, regardless of what the INR